like to invite the next group of panelists to be up here so we can get ready for Singapore. I think it's Dr. Almagor, Dr. Chen, Dr. Colombo, Dr. Fu, Dr. Hong, Dr. Kim, Dr. Kleber, Dr. Margolis, and Dr. Wu. This is working? Good afternoon. Can you hear us, Dr. I think they can hear us. Dr. Tan? No, Huay Cheem, yeah.
Hi.
Okay,
yes,
Huay Cheem, now we can hear you. So,
can you hear us?
Yes, thank you. So we have a great group of people here to sort of go through things with you. We have Myeong-Ki Hong and obviously S.J. Park and myself, and Dr. Almagor, Dr. Chen, Dr. Colombo, Dr. Fu, Dr. Hong, Dr. Kim, Dr. Kleber, Dr. Margolis, and Dr. Wu. So this is a session about BRS, so I presume you're going to show us something regarding that. Go ahead.
Well, certainly an outstanding panel of moderators and chairperson. So anyway, we'd like to thank the Dr. S.J. Park and the committee for giving us this opportunity to transmit from National University Hospital. So I believe this is the second time we are transmitting for this particular course, and so it's our privilege, and with me is Dr. Joshua Loh and Aisha and the whole team. So we're going to start off by telling you about the story of this patient, Joshua.
Yeah, can we show the slides, please? So we have here a case prepared for you. It's a 66-year-old gentleman. He first presented to us on the 6th of April, that's 20 days ago, with an acute inferior posterior MI. And he underwent primary angioplasty to the distal RCA. And for today, we're going to do PCI to his residual lesions in the LAD and the circumflex. He's got a cardiovascular risk factors. Next slide, please. He's got a history of chronic heavy smoker, otherwise non-diabetic. And during the index admission, his LVEF on echo was found to be 65%. So that's normal function. So maybe we can show the
Okay,
RCA.
so this is really a stage PCI of a patient with multivascular disease presenting with acute inferior MI. You will realize that we don't quite go along with the culprit and the primary trial. We still stage our PCI. We don't do all the lesion at the same time. So let's just show the angiogram right now.
Let's show the RCA,
I'm going to show
please.
the RCA for shot. Can you see the picture? No, switch to the live picture, please. Live feed.
Show the lateral plane.
Okay,
Yep.
so the RCA is widely patent, as you can see. There's a bit of moderate stenosis in the proximal segment. So this was a culprit lesion that was completely occluded. I think the stent is right at the distal segment. So that was a combo stent. And so we're going to show you the left coronary system right now. So can you see the left images now, beginning with a frontal view? Let's have a frontal view.
Yes.
Epicranial view, please. First shot, please. Shot before this. Shot before this. Okay, that's good. Can you appreciate this LAD, which has got multiple lesions actually, proximal, mid, distal, show really a long diffuse stenosis here. Spider view, please.
We don't see the distal that well because the injection sort of
Spider
faded
view.
by that point. Let's see.
Right, so the distal part is really not the main focus. So we pretty much just concentrate on those within the view. Yeah. Can I see the spider view, please?
We see kind of 3 lesions.
So the spider view shows that there is actually also a circumflex stenosis.
Right.
Correct, correct. Next shot. RO caudal, next shot, please.
Well, you have pretty severe disease in the distal LAD before the
Ellen,
bifurcation,
right?
yeah.
Correct. And if you look at the circumflex, there's also significant disease along the proximal and the distal circumflex. So this gentleman has really multivessel disease here, and so today what we want to do is really to show three things. Slide, please. So, Alan, what we're going to do is to show off a new sort of catheter-based FFR device here, which is marketed by ACES. This is called the RXI nervous catheter. So this is not like a pressure wire. This is really like an IVUS catheter where you pretty much thread this catheter, to measure the FFR. So you basically use a patient's your own coronary wire, or you just thread this catheter. So I'm not sure whether it's available in overseas and elsewhere, but we're going to show a catheter-based FFR just to document that this LAD and circumflex lesions are indeed hemodynamically significant. Then we're going to be showing use of BVS techniques, overlapping techniques for such diffuse stenosis. I think BVS really works. I think it will be an appropriate choice here, given the extent of the disease. We really don't want to put in so much metal here. Having a biodegradable scaffold just makes sense to us here.
Okay.
And finally, we're going to show this new Illumin of this OCT system.
Great.
Okay, so any comment from panelists? And
so maybe go back on the strategy for 1 second. I think, given all the data with PREMI and culprit and also anybody would do a complete revascularization in the same setting. Unless you have, hopefully it's not middle of the night, right? You have to hold the whole left system, the circumflex system. So clearly, I don't think anybody would be doing that whole left system in the same setting according to like a PREMI protocol. Too much to do, right? It's just not possible. Would you do that?
I would like to comment that I agree with you that we will stage the LAD first and the circumflex. The circumflex is relatively straightforward anyway. The LAD is a classical case for BVS. I don't think you can find any case which is as good as this one. So it's congratulations. It's a real beautiful case.
So, Antonio, you mean that to fix the distal area as well with BVS?
Yes,
and
yes.
your sort of complete revascularization with BVS
the
approach,
beauty
right?
of the BVS is that you can fix also maybe, I wouldn't say intermediate, but some lesions that is not strikingly critical.
So we'll come back to that maybe once you, Cheem, let you go ahead and
so
do
there's
some.
disease.
I'd like to ask...
So what I want to do here is to show this ACES FFR catheter. So if you look at it, Joshua is here, and it's actually a much easier system to operate than the pressure wire of, the Certus pressure wire. So if you look at the console, pretty much it involves just plugging in the system into in the console here. Okay, just show that green connection part. Back out a bit. Okay, so you just need to plug this thing in, and automatically it says, aortic pressure.
So this system, no need to equalization.
And then the next moment, what you need to do is just immediately just load this onto the wire.
Wai-Kwong is
No, you will still need equalizations in the catheter system. I'll show you.
Okay, back to...
Wai-Kwong is the beauty of these devices. You don't need equalization.
This is a catheter-based system, remember.
Is that true? Is no need equalization before you plug in and plug out? No need, or you should.
No. You equalize. No, you. The equalization does not occur there. The equalization occurs in the patient.
You still need to equalize. It's just obviously go through a wire.
So they just merely detect the aortic pressure.
So Cheem, to cut off is the same.
So the biggest advantage, as I see, of this system.
Sorry, just a delay in sound.
What is that?
I was just asking, what is the cutoff value for the ASIS NAVIS system, because it's going to obstruct the lumen a little bit. So do you change the cutoff of the 0.75, 0.80? Is that validated, or is it, you just basically use the same cutoff for now?
Well, actually, there's study that validates this against a certain pressure wire, and it does very well. Actually, I don't think it occurs very much of the catheter, although it might be larger in terms of profile compared to just a pressure wire. But I don't think it's going to affect the lesions in terms of measurement so much. So what we do here is that if you can see the monitor, now, the marker, the transducer is actually, can we show the angio, please? Just proximal to that radio opaque marker. And this is where we're going to be equalizing. And I'm just going to show you how we equalize on this ASIS system. All right, let's show the camera again. So just simple pressing of one button, and that's it. You don't even have to wait for 30 seconds for equalization. We just wait for a while. Let's press again to 1 point. Okay. I think the system has got an advantage in the sense that, well, we're getting more drift than I'm expecting. This system is supposed to have less drift compared to a usual. Can we equalize again? This is equalize.
Flushed it already. Okay, now
Can
it's
we
stable.
show the monitor to? I think there is a turning here that's really affecting the drift. Okay, once it shows 1.0, we can just simply advance the catheter.
Back to angio.
Angio, please. Okay, so let's see the monitor now. And switch to FFR. So without giving any sort of vasodilator, this is already a significant stenosis. Would you agree?
Yes.
Is this the baseline FFR?
So back to angio again.
Wait, Cheem,
So
this distal
what we're
LED
going
still
to
has
do here is
lesions.
we simply load this catheter into the... Correct.
Despite
But
that.
it's so distal that I don't think it's worthwhile doing anything about it. And despite this, is it still significant?
Sorry, did you assess the distal lesion as well?
Let's do the cert.
Dr. Tang?
No, so we just assess the proximal 3 lesions.
So you're not going to do the distal?
I didn't really go all the way down. I don't think we need to do the distal. It's just too near the apex, and I'm not sure what is necessary. Does the panelist think we should deal with it? I'm open.
I think it's pretty tight distally. Maybe just a balloon of it at the end, some point, maybe something worthwhile. But we can deal with it later on.
Okay.
So you're going to do the FFR of the circumflex
I'm just going
now?
to show you this, how quickly we can do this FFR. Correct. So we're just going to press again to show the FFR, press equalization. Okay. Okay, so I'm just going to advance the catheter now, just to see whether the circuit is also significant.
Wow, look at
Can you
that.
show the FFR again? I think it's clearly ischemic too. So this is how good how convenient this particular catheter-based FFR system is. So I think we have demonstrated ischemia here. So I think it's justified to do a PCI for these patients.
It's the green wire.
So, Hui Cheem, which one are you going to fix first?
So LED. It's more exciting to fix the LED.
So,
I think
Antonio,
this is more important of the two arteries here.
would you fix the distal part of the LED as well? You saw that the LED distally has a bit of disease beyond those three lesions.
Yeah, I think I will fix the distal part. The distal part most probably will be a 2.5, post-dilated at high pressure, mid 3.0 and proximal 3.5 for sure.
Show the OCT.
Yeah, before that.
I think the LED distally is bigger than you thought, and it goes into two big
before
branches.
we do,
Wouldn't the distal lesion be a good indication for a drug balloon?
so it is possible we can use a drug-eluting balloon, but I'm not sure about the role of drug-eluting balloon in de novo lesion. So, Ellen, would you do any intravascular imaging before we consider BRS since we've decided?
I think it'll be helpful just to kind of see, especially since it's such a long, diffuse disease, to kind of get an idea where's a more normal area. I think, those proximal three lesions, if you have time, and, whether you can get an OCT run on it.
But the OCT will be a poor image because the tight proximal lesion will impair good.
Maybe pre-dilated first.
I think you need to fix the proximal lesion first, and then if you want. My main question is the distal 3 or 2.5? That's my unanswered question. But I think you have to fix the proximal to do good OCT.
Okay.
Yeah, but another issue, Antonio, is that...
So I think OCT imaging will be very good. I think
you might want to fix the proximal lesion and don't do the very distal. After you fix the proximal or the mid lesion, you do FFR on the distal lesion. Is it necessary to go so distal without any physiological assessment, or you just go there because there is a lesion there?
I think with the BVS, you can be a little bit more liberal to fix, I wouldn't say intermediate lesion, but this type of lesions. I will fix the proximal, and then you can do FFR. Of course, if you find that the distal has a 0.9 FFR, that's out of the question, that you should not do anything.
Why should we be more liberal with a BRS as compared to a normal stent?
That's a good question. It's because it's like it's reabsorbable. It's like if you eat too much sugar, it's not. It's low calories.
If you have a plan to the BRS in the proximal LAD, would you do me some favor? Fix it the LAD with a BRS without the OCT guide, and then verify prove it that the scaffold optimization finally with OCT. Not use the OCT before deploy the BRS. So most of the common junior interventionists they worry about that the angio-guided BRS implantation. So please show us that your technique without the BRS implantation, without the imaging guidance, and then finalize that the result with the OCT.
Actually, I have a different strategy. I think that if you have decided to want to use OCT as a imaging modality here, I might as well use it to assess the lesion diameter as particularly for tapering lesion. This one looks like a pretty uniformly enlarged vessel. But when you have tapering lesion, when you want to decide on the size of the scaffold to choose, some form of intravascular imaging will be very helpful. So I've decided to use an OCT, and this is the latest Illumient optic system. I'm just going to do a run of the OCT for the 2 proximal lesions and let you have an idea of what this lesion is like. We didn't pre-dilate, we just simply put a catheter down. Can we show the run?
So you had a run already before, right?
We can have some comment from OCT experts on the panel. Yeah, I just want to show you now.
Okay, good.
So I'm going to go ahead.
Mm-hmm.
Can you see the OCT run?
Yes. But we got it at the end though, a bit.
Can you play from the beginning again?
Yeah.
The last run.
So these images are used with dextran injection rather than contrast.
That's for me.
It looks quite good with the dextran, yeah.
So we think that this dextran, looks better and probably less hallucinogenic as well. Up.
This is the smallest area there.
12.
18.
1.8. Stall. So this 25.
So what do you think the size, Antonio, distally
Any
is?
comment on the
almost
OCT?
2.5, almost 3 at some point.
2.0.
Yeah.
Tap.
I think, I still, honestly, to size, I'm still more in favor of IVUS, but I think you can guess also by OCT.
You prefer IVUS, okay.
1.8.
Let's just see the wide. Okay, so we finished the OCT. You're going to pre-dilate.
So we're going to take our. So I'm going to show you the measurement. Yeah. So can we show the measurement here? Just beyond that second lesion, the reference vessel diameter is about 2.8. The very proximal part of the LAD measures 3.3. Can we just show the measurement? The MLA is very tight. It's 1.1 at the 1.3 at the proximal, and 1.1 in the mid. 3028.
Okay, you want to take a picture? Good dissection.
Okay. All right.
Why
3028.
What size of your what size of your pre-dilatation balloon? You do it the pre-dilatation, right?
It was just a 2.5.
Or 2.5.
Yeah, just a half a size smaller, 2.5. I use a non-compliant balloon just in case this is a tight lesion. I think for scaffold, we really need to prepare the lesions properly. But the fortunate thing is that this is not a very calcified lesion, so I think it works pretty well with just pre-deal.
In our practice,
So
I think
in this current context of
in our practice, we like to use a 3.0 instead of 2.5 because 3.0 because the distal reference 2.8 to approximately 3.2. So sometimes I use a non-compliant balloons for the pre-dilatation and also for that post-dilatation. So you can save one balloon.
We went up to 18, no?
yes, in fact, that's exactly what the European bifurcation clubs is now recommending. So in the situations where you have a tapering vessel, where there's a discrepancy in terms of the diameter, distal and proximal, you could actually choose a somewhat in the intermediate range. So for example, this is a 2.8. I would take a 3.0 and then go gentle, and then proximally we can always optimize with a larger balloon.
I think the distal lesion already looks better. The very distal LAD.
Yeah, the very distal looks okay. I think
Oh,
I may not do anything.
But do you have any concern about putting this scaffold in this proximal mid LAD with a lot of septals that comes, and some of them are really stenosed? Do you take into consideration the thickness of the struts, etc., just to make some argument?
I think it's a real concern. I think if you have a branch of less than 0.5 millimeter, Muhammad Zhu paper does tell us that there's a higher incidence of side branch occlusion. But I can live with some septal occlusion, but I just want to make sure that the LAD is properly dilated.
Take a picture.
treated test for me, please. So I think, as we all know, for BVS, we have to go up slowly, 2 hemispheres every 5 seconds. So we're going to do it slowly, Ria.
All right, going up 2, 4.
So these are 2.5 or 3.0?
6,
3.0.
8,
It's a 3.0.
10.
Distally measured about 2.8, so I think a 3.0 will be nice. I think it looks pretty good, actually. Floral stuff.
The OCT is always a
we'll
little
hold this up.
undersizing the lumen, so.
Just going to keep it a little bit longer. This is a long, yeah.
Dr. Tan, are you going to overlap the
So it's
stent?
about 45 seconds.
I like to do multiple
Down.
inflation. Yeah, we have to overlap all the way to the proximal. But I'm just going to dilate one more time. Our Japanese colleague taught us that multiple inflations helps to expand the metallic DES. I don't see why a bioresorbable scaffold will not do the same. Florestal. So we're going to be putting a number of overlapping BRS here. Down.
Down.
I know there are many techniques. So what is your preference, Dr. Colombo?
We try to do minimal or no overlap to place the balloon marker at the level of the platinum marker. So this guarantees almost no overlap or minimal. But you know, with the foreshortening of the angio view, it's always a dream to pretend to be precise.
But, well, okay, but we will try in anyhow to try to make sure that there's a minimal overlap here. Given that this is really a thick strut device that we are looking at.
So sometimes if you have to land precisely in the proximal segment and you want to be very precise to limit overlap, in some situations you have to start from proximal to distal. Otherwise you end up not having enough room or having too much room proximally.
So, Cheem, you're
Yep.
planning to
So
do
we have a bit of,
three BRS, or you're going to need 3?
Yeah, I think so. Yeah. Would there be any concern? I think this is really the best situations to use a bioresorbable scaffold when you have a large, long lesions like that, and you really don't want to have any long-term prosthetic material left behind. This is an indication for bioresorbable scaffold. Although this patient is somewhat elderly, in Singapore, unfortunately, we do have a criteria of no more than 60 years old for the use of resorbable scaffold. But for this patient, I think we'll make a special exception.
If you're going to put a long bioabsorbable scaffold in the proximal and you decided to do the distal, which I don't think you should do, but if you did, would you mind putting in a normal stent? Would you have an objection to that?
So some people do to go for this hybrid approach. I think if I have decided to use a bioresorbable scaffold, I try to stick on with it, unless the size of the vessel is not suitable for it. For example, if the proximal is just far too big, more than 4.0. But otherwise, I would try to stick with bioresorbable scaffold to maximize the benefit of whatever there is of this device. We know that bioresorbable scaffold has got this restoration of motor function, possibly remodeling effect. So, yeah.
Dr. Tan, would you further predilate the proximal lesion before you put in the BRS in the proximal LAD?
I've already pre-dilated all of them, so...
but you used 2.5.
And the first scaffold went in quite okay, so... That's correct. When high pressure, it's not a very calcified lesion, so I think it went in pretty nice. So I want to show the overlap here.
That's good.
Can we have a higher Mac here?
What size of the
So I'm going to use the device platinum marker. Okay, so can you see I'm going to magnify it?
What is the size of second BRS?
Align them pretty much.
What is the second?
What's the size?
second
It's
BRS?
3028 again.
3028.
30
Yeah.
is the same size. The OCT measures it to be 30 until proximal is 3.3. Okay, I think we can go.
Yep, okay.
Up slowly again.
So you're basically
Going up?
putting the marker on top of each other.
2.
Correct.
4.
Low magna. Okay. 20, 16 inch.
6. 8.
So Alan, I know that it's approved in state, so how is the take-up rate like?
10.
Sometimes we have difficulties, putting a second BRS into the
12.
first because the strut is actually somewhat thicker than the usual
1-4.
metallic tier. So some of the practice we like to do a high pressure inflation for the first BRS to try to expand it a little bit more and facilitate the second BRS to be overlapped. Sometimes we, especially angulated RCA, sometimes we have difficulties second BRS into first BRS.
Down.
I think angulation would make it, it's always an issue. So
Yeah, I
you have
think
to-
I agree with that.
So because
So
the
I also
length
like
is
to go high pressure in the first round.
because the stent length is still limited, I think, Dr. Colombo was thinking, I heard that, would you consider putting the proximal one first? Then you can nail down that area and then go distal to it. Then you can be more precise. But now it's kind of difficult to know how long it's then you need to put the third one.
That's my limitation. I think now you have to cut the stent because you don't know the exact length. With the meta stent we used to cut the stent.
Okay,
Maybe you
we
can
will
do
measure
also
the length.
with
Measure from
bioresorbable.
the balloon as well.
Let's go to our corner view. Yeah. Centralize, please. So we're going to measure a bit.
So you're going to bring it all the way to the ostium, huh?
Can come back a bit.
Perhaps no need. Let's see. I'm just going to take a picture here. Let's see how it goes. Let's take a picture. The ostium of the LED looks okay, so I don't really have to go all the way to the ostium. So I can see the marker from the second scaffold.
Maybe an 18 would do.
Half of it will be 14.
14,
So,
yeah.
yeah, I think 18 will be more than sufficient.
There's enough landing proximally, I think.
It's 30, 30. Yeah. So what is the penetration rate like now for BRS in your various centers?
Maybe you can ask Dr. Wu in Taiwan, what is the incidence of use of BRS?
Because the Medicare reimbursement is not approval yet, so we still have to pay from the patient's own pocket. So that's currently, I just talked with Alan, that's 2 times higher than the regular DSO. Our penetration about 10% in Taiwan.
We don't know how much is the DES.
Yep.
You say twice. So how much is the DES?
About, I think it's about 15,000. Oh no, 1,500 US.
How about Iran? How about in Israel? What is the...
DES is around $300, and so come to work in Israel.
$300?
And
I need to bring a suitcase
scaffold
and buy
is around
something,
3 times more. I mean, around 900.
Antonio, how about in Italy overall? You think what is the penetration
The
rate?
penetration in our center is about 20%, but is getting higher. I think, especially, I expect that with the new generation will really increase. So it's,
SJ, what about?
We just started, and for the very selected cases, it's big arteries, and so less than 10%.
So in the US it's easy, we don't have approval yet, so we still made it in trials, but hopefully by summertime we will have the BVS approved.
But, you know, if I may add, in the private hospital where I get referral of diffuse disease, this type of lesion, the penetration goes up to 60%.
For the third one.
So the BRS also 3.0?
But that's what happened now. That's exactly what we have talked about. Is sometimes you really need to do good dilatation of your scaffold before you enter with an overlapping stent. Especially if the vessel here is 3.5 and you have 3.0 stent. So you must do NC balloon, very good dilatation.
Yeah, we always do at the beginning, after each deployment, do optimization and then continue.
So, Antonio, you don't have much problem if you do it from proximal to distal because you have the capacity, obviously, the bulkier stent through it. But once you optimize it, it seems okay, right?
If you don't have IVUS, that's the best test to tell you if you have deployed the stent well. If the stent does not cross, it means that it's not well dilated.
Thank you.
And there was a continuing imprint on the balloon, so definitely you need to check with IVUS.
18.
1/8.
But I think with the current delivery balloons, you have to post-dilate 100%.
Before putting the second stent distal, right? You have to optimize the proximal, get it fully expanded, and then you deliver the next one.
Yeah.
Dr. Kleber?
Correct.
Any comments or use of BRS?
Let's take a picture, buddy.
Yep. Okay.
Messed up.
Okay, that's good.
Okay, so I think we have prepared.
We're ready.
Enough.
Thank you.
Dr. Colombo, how big could you make 3.0 PVS if you need to match the proximal LAD size? Do these increase in diameter just like the metallic stents?
But no, usually, you know, we don't want to go higher than 0.5 millimeter, usually 3.5 maximum. But most of the time, if you have done good sizing, you really don't face this problem.
So, I think probably we need a 3.5 to maximize that, the entry of the second BRS.
Yeah.
Yeah.
I think once you have a slight angulation,
anyway, you need a 3.5.
And also because of the angulation, there's a little bit of angulation. So what I'm going to do is actually do a body wire here. That is the challenge of a scaffold in terms of its deliverability. We know that, but just help me back up.
No problem.
So we don't want to try very hard in terms of advancing the scaffold. Certainly not the way you do with metallic DES. So anytime if there's concern.
Can we get a what wire? Seung?
Just another.
And
So run through.
also, I think it makes a difference. Sometimes
So what
we
I'm
have
going to do is
seen
to do a body wire.
that post-dilatation at 20 atmospheres, and then you go to 25, 26, makes a difference. So the word post-dilatation is not a yes and no. Depends the amount of pressure you are giving.
Is there any risk of damaging the struts
Sure.
if you went
But
really
this
high
is,
pressure?
The struts are dependent on size, not on pressure.
Well, I
So-
think you don't want to go beyond the recommended pressure. Yeah.
But you're going to use an NC balloon to do that, right? So a bit safer.
But this is a very nice example of either you do very good lesion preparation from the beginning, you size it with IVUS OCT, you go to the nominal size of the vessel and then you deliver, or you have to work it out as you are doing right now because there is some angulation going to the first stand, to the mid stand, so you have to go to a bigger balloon size, most probably, or you do body wire, etc. But it becomes quite a complex,
Maybe the balloon again.
more laborious.
It's obvious. It's not difficult. It's time consuming. You have to be patient and.
Got it.
So you have a body wire through these LED stands, and you can try to stand again.
Yeah, so I'm going to optimize it with higher, even higher pressure balloon.
Okay.
Dilatation. So let's optimize everything first before we start introducing the scaffold. So it's already gone twice in, then we want to make sure that you get it right the third time. It's quite a bit of...
Is it the wire wrap or? Stick out the sub wire.
Are you on the original wire or the new wire?
That's fine.
Did you think about the
I'm
wire
on the
bias
new
in
wire.
the circ? There is some angulation in the bifurcation lesion. Maybe inhibit the. Okay, good.
Correct. So that's why I've already taken out the circ wire.
There you go.
Okay, let's test. Let's test. So I'm going up again. So let's go to 20, 24. It's a good stretch here.
2-4.
May I ask about the total
Down. This is the NC balloon, so it's okay.
length of the BRS? Total length, 3 over summation of the 3 BRS, more than 70.
So the total length would be
28,
more than
76.
56, 70, 76.
70, yeah.
I worry about the minimum lumen cross-sectional area in the proximal LED. You deploy the 3O only, so if we do the OCT, if the minimum lumen cross-sectional area around the 5 or slightly above the 5O in the proximal LED might be a not so the bigger one, greater size.
So the OCT shows that the proximal MLD is about 3.3. So we can take it up to a 3.7 if necessary. So we have the OCT to guide us here. So that's
Post-dilation in the proximal portion is
now
done
is
with
to see whether it can go down.
3.5. 3.5 non-compliance balloon.
No, it was 3. I still stick with 3.0 or 3.5?
Yeah, that was 3-0.
3.0 still.
Yeah, but very
Thanks for
high
me.
pressure. I think a bit further.
So it tells you that we need to, okay, let me
It's a
just
bit further.
overlap a little bit here first.
Yep, that's good.
I think I want to take out the other, I think we can leave it, no problem.
Should be okay.
Has anybody trapped a side wire before? Has anybody trapped a bioresorbable scaffold before? Hi, Mac, for me, please.
Do you remember which is which?
So you can bring that GL well
Then
before you
we'll
deploy
be
it. We have one case, forget to bring that well outside of BRS and
Okay.
actually trap and also
I'm going to
fracture
thorough stop.
report in the International
Alright.
Journal of
Test me,
Cardiology.
Yeah, okay, yeah. Should be good.
Is it okay?
Yeah,
It's overlap.
it's
Okay,
overlap.
let's go.
So what would be the reason to leave
Going
the
up,
wire
2.
wire
You should
inside.
take out the
Why
other
don't
wire,
you take
no?
the wire?
4, 6,
You don't need that. Yeah, I think you should take the other wire out.
8,
Is the Dr.
10.
Whose comment is
Okay.
there
I
is
was
a
thinking
chance
about
of
it,
the
but
trapping
I
of the
become
wire,
lost,
the
so
body
which is the
wire
real
when you
wire?
deploy the.
Forest out. 1, 4.
You
Why
want to
just
try the
like to
trap wire?
demonstrate how is the jail
1, 6.
wire? For the size, Antonio, maybe I would prefer use a 3518 instead of 3018. What do you think? You know,
Yeah, I think in the very proximal
1/6.
LED, you should use a 3.5 unless proven otherwise.
We have office.
So wait, Cheem, why did you leave that wire there?
Honestly, I got lost which one is the real wire, so. Okay. So I better make sure I don't pull back the wrong wire. But it makes no difference, I think.
Okay.
Let's take a picture here. We'll figure it out in a short while. Okay. Okay, let's take it out.
Yep. So, Antonio, what will be the maximum size of 3.0 that you can overexpand, like half a number? Or
Yeah, 3.5.
3.5.
You know, they say that if that's something on the side, if the BVS is very fresh,
You want to take this off,
very
please?
distant from the expiration date,
This
you
is
can
the gel
expand
one.
even 1 millimeter. But this is off-label.
Okay, you hold the guide. Yeah.
Right.
Coming up. Okay. Let's take a picture here.
Yep.
Let's okay, let's take a picture here. Oh wait, hang on. Let's have a better picture here. Okay. Get a good one.
AP crane.
Let's go to AP crane. So,
angiographic
should I
appearance-
dilate first or should I do an OCT first?
In an angiographic appearance, there is some minor residual narrowing at in the most tightest
Single
portion in
plane
the
A.
pre-intervention.
Very nice.
Wait about in the proximal? Or?
Yes. If you the pre-dilate the proximal portion with a more bigger
so
size
what
of
we
the
can
balloon,
do,
maybe
3.5.
you can achieve a more.
Shall we do OCT first? Shall we do OCT first and let you see how much more we need to do in terms of work?
So Wei Cheem, do we have about, I think, 10 more minutes, and then we have to go to lectures because we're going to go to Australia
So
after
is,
this.
Okay, let's quickly do it.
Is the first septal deteriorated a lot?
Understand.
It's a little bit of concern because it's not a trivial septal.
Shall we, is the OCT okay? I think the septals are
Looks
all
the
still
same.
preserved, huh? Okay, are we ready for the OCT? Do you have to check?
Dr. Wu, do you prefer the 3.5 balloon in this case?
We're good.
For the proximal, I probably like it 3.5 because
I will probably
same as
go higher
Antonio's
pressure.
opinions. I prefer 3.5.
Yes.
Not
Yeah.
yet.
Maybe
It's on the finger.
3.5 occlude
Yeah,
the
okay.
septal branch.
Let's go.
Yeah, so I think we probably will have to go high pressure. Yeah, I might occlude the septal branch.
But I may
It's
make an
tolerating
attempt
very well,
to
I
go
think.
into the septal branch with a wire before going with the 3.5, because I
20 inches.
I hate to lose such a big septal.
Right.
May take a while, but with a new generation wire, Sion, I think you can get inside.
But okay, come nearer.
We need 2 runs.
Yeah.
But even we have a side branch chair by the BRS. In our series, we easily to get wire. We can rescue it by using a snuggle case. That was not a problem for even. Although the straw is somewhat thicker, but this kind of rescue is not a problem.
Yeah. Yeah. Okay.
Ready?
He wanted to refill the dextran.
Refill. Okay.
Yeah, I have here.
We're done?
Oh, we don't have, is it? No more.
We still have, but they said they wanted to refill.
Never mind, we do.
How much is that?
Can do 2 runs?
2 runs?
Yeah.
May not be.
Can we do 1 run first?
Okay.
Okay, we'll do 1 run. Okay, let's do it. I'm open already.
Open? Yeah.
Yeah. Go ahead. Okay.
Turn. Okay.
So you think we need to pull back a little bit?
We are interested in the proximal part with a minimal scaffold area. Please measure it.
Okay, so he wants to. Do we have enough, or can we fill up quickly?
Let's fill up quickly.
Yeah.
Come.
Let's play back the
You need to take this
OCT
out, yeah?
first while we are topping up the dextran here. So let's switch the OCT images. Can you see? Right. This is coming from the beginning, distal end.
All right.
Okay, so we haven't quite gone beyond the
Quickly.
scaffold.
Okay.
So it's quite well opposed, as you can see, the scaffold. Do you agree?
Yes.
Okay. Come closer.
I think so far so good. We might just go and touch up a little bit along the way. Approximately, probably will need more work here.
Okay. Yep.
Okay.
Let's
so
flush.
we're going to do the. Let's check it.
Flush.
We're going to do the
flush,
proximal part to.
Okay.
To let you see the ostium. Okay, so about here. No, this one will come back. You will go down. Yeah.
I need to come in a bit more.
Okay.
About here, huh?
Okay.
Okay.
All right. Let's get ready for a second run.
Okay. 2 patient.
Open already.
Yep.
Go.
Let's go.
Inject.
Yeah,
Okay,
open already.
All right.
Mm-hmm. Okay, turn to patient.
Okay, let's play back
I'll
the.
take this out.
Let's take it out. Yeah.
Can we get a 3-5-25? Yeah. Okay.
Maybe a 3-5. The
Oh,
recommendation,
3-5, huh?
3-5.
Okay.
It's actually very well expanded, you know.
Mm.
Over here, so.
A few spots of incomplete deposition, but not too bad. A little under-expansion right here.
We're going to optimize it with a high pressure balloon here along the mid segment So this is the very proximal part of it. Are you okay with it?
Looks okay, but the lumen is a little smaller. Yeah.
Okay, let's swing back a bit to... Correct. Go back to the proximal scaffold. Yep. Go to the left. Towards the end. Okay, good. This is the proximal LAD here. Slowly, slowly.
3 minutes.
So what would you do that? We have limited time, so 5 minutes left. And so did you do the high pressure?
So I'm going to take a 325. I'm going to 325.
Not yet.
Yeah, so I'm going to do it now.
Do it now.
So I think the recommendation is to take a quarter size non-compliant balloon,
Some very
high pressure,
small
and get it up to a 3.5.
dissections in this proximal part.
You see how behind are we with the technology? For example, we do not have yet a non-compliant balloon as flexible as a semi-compliant balloon. Can you imagine if this scaffold could be mounted on non-compliant balloon deployed at 22 atmospheres, period?
You want to go all the way down or just...
Now you have to re-go, recross,
reflate. Can we see?
All the way, yeah.
Okay.
Is that a little bit dissection proximal to the...
Okay, somewhere here.
I think it's okay. Right. Very small dissection.
Dissection in the...
I think it's just a very small one from OCT.
Right. So you're going to do high pressure inflation, non-compliant, 3.25.
This one, on there, that's 6 o'clock position.
All right.
Yeah. Yeah, 3.25, that's correct.
Okay. So did you do in almost all PBS cases using the OCT guided? OCT guided? In all cases, did you do that?
I think I do. Yeah, I do. Correct. Correct. Because I just cannot see these scaffold positions very effectively.
In retrospect, it might have been better to use a scoring balloon or a cutting balloon to prepare this artery.
Got it.
Yeah. So what pressure did you apply?
So I think we are probably towards the end. I'm going up to 18 hemispheres. I'm going to be, I was told the transmission time is nearly over. So today I think we showed you the use of catheter-based FFR and overlapping VBS, BRS scaffold implantation technique. And then again, interestingly, we will show you some of the problems with the deliverability of this device, and finally using OCT to really optimize the final outcome.
2-0.
So just in case I get cut off, but thank you very much for this opportunity again, Dr. Park.
Okay, just 2 minutes left. More.
Up.
So
2-0.
How much you go?
2-0.
Okay, 2-0. Okay. We're going up to 20 hemispheres here using a 3.25.
Okay.
Coming. There's a bit of dissection in the proximal.
Cheem, what are you going to do with the circumflex? Are you going to just use a metal stent, or are you going to also BRS that lesion?
I think this one can go easily with a bare metal stent. I mean, with a DES. Yeah, I think the advantage of a BRS is not so significant, I think, as opposed to LAD artery. What do you think?
Probably. Here's a DES, a combo stent in the right coronary already, so I think just concentrate on LAD with the BRS.
Right coronary lesion itself is FFR. This should be checked.
Yeah, I think it's
circumflex is just small side. DS
we'll
is
do
okay.
FFR. Okay, to complete the picture, let's do the FFR. Let's take a picture. After all, this is a catheter-based FFR, so it's quite easy. Low mic for me, please.
Are you doing FFR of the LAD, or what? What are you doing?
Yes, we're going to do it. FFR of the LAD at the request of Dr. Park.
Off already. Oh, cut off.
Okay, I was cut off already anyway.